Hi everyone, we're about to get started. One question, one follow-up, 30 minutes, and I'll turn it over now to the doctors.
Good afternoon. And again, today we're going to be, besides doing the numbers, there's the focus still continuing on long-term care. And as you've heard from the announcements, the aspect of dealing with congregate settings and the issues and the matters in there was announced today by the ministers and by the Premier. And so that's another area of focus that we are going to be working at even more certainly than we have in the past, and we continue to deal with that. So I'm going to ask now for Dr. Yaffe to talk about the numbers, and then I'll come back with some comments on that accordingly. Thank you.
Okay. Thank you very much. So, as every day, I will be reporting the data from the IFIS, Integrated Public Health Information System, as of 4 p.m. yesterday. Total of 12,879 cases, confirmed cases of COVID-19 in Ontario, representing an increase of 634 cases from the previous report. Of these, 57% are female, almost 45% are 60 years of age and older, and 60% are people who live in the Greater Toronto Area. At this point, unfortunately, we've had 713 deaths reported in this database, which is an increase of 54 deaths from the day before. 52% of cases, or 6,680 cases, have been resolved. So that's going up, which is good. We have about 12.5% of our cases are in healthcare workers at 1,626 cases. Again, this is a cumulative number and does not represent those currently positive. We have 887 people currently in hospital with COVID-19. 223 of them are in ICU, and of those, 185 are on a ventilator. In terms of laboratory testing, now we have tested 194,745 people in Ontario, or tests have been completed in Ontario. And there are about 6,757 that are currently under investigation. In the last 24 hours, we've completed 10,214 tests. Going specifically into long-term care, as you know, I've mentioned we have two different databases, and we have begun publicly reporting both the data from the IFIS data, Integrated Public Health Information System, which is the system public health uses, that looks at the case investigation and epidemiological data, and the Ministry of Long-Term Care data, which is more of an administrative database. So I'm going to report on the Ministry of Long-Term Care data as it is more current. As of 3:30 p.m. yesterday, 132 long-term care homes were in outbreak, which is 5 more than the day before. 2,189 residents were confirmed cases. 1,058 staff were confirmed cases. 516 resident deaths reported, and 1 staff death. As you know, yesterday the government provided an update on the actions that have been taken since the launch of the COVID-19 action plan for protecting long-term care homes from last week. And this included increased testing both on symptomatic and asymptomatic residents and staff. To date, almost 14,000 tests have been completed, particularly among residents in long-term care. Additionally, 21 long-term care homes have done more testing of asymptomatic residents and staff outside of the testing guidance in order to help understand the spread of the virus. There are 31 infection prevention and control interventions currently in progress, and these include training and measures to support better and more effective physical distancing in the homes. Across the province, as you know, hospitals have redeployed much needed staffing and infection prevention controls to long-term care homes. For example, in Toronto, 5 hospitals have been engaged to support approximately 40 long-term care homes in the city. And now I'll just turn it back to Dr. Williams.
Okay, well, thank you. And it tells you a lot of activity being undertaken at this time, and especially in regard to long-term care. As you can see, the amount of testing overall, well above 10,000 and heading up with our increased surveillance that has been undertaken. That number will no doubt increase further towards our limit. In that regard, if you look at the numbers that we reported for today, the ones in our numbers, well over 300 were from long-term care in our outbreak modality, and related to our retirement homes, another 100 about. So while we don't know exactly, and I've been asking our different analytic groups to separate the long-term care retirement home aspect out of the ones from the community so we can get separate curves on a daily basis, and we're hoping to have those numbers instead of some general calculations that when I look at it and look at the data, as you said before, we have been coasting somewhere in and around the 400s. This would give us a mislead to think that we already dropped below 300. I'd find that surprising, and so I won't jump to that conclusion as I guess as helpful as that might be. I won't say at the moment, but I think it is certainly coming into a better scope as we get that clarified. But no doubt our assessment centers have been busy, still seeing people with a wide variety of symptoms, and not just the mild ones, but also the ones that we have enlarged the definition of potential signs and symptoms that are compatible with the growing variety of aspects related to COVID-19. The announcement today with the congregate settings is another area that health units up till now have been dealing with on outbreak by outbreak basis. And as of course, as we try to focus on those, we're going to do much the same process of looking at the many different variety of ones that are there, and some have always been in our high-risk category, such as remote communities, indigenous population areas, and as another area, not that they're congregate, but to relate to that, and some of the settings that are in some of the municipal jurisdictions, to make sure we look at that interface between that and our communities, and to ensure safety and ongoing protection of the rural and remote communities in that regard. So that's another whole foray to move into, with looking at ideas around, as we said before, much like with the long-term care home, doing the assessment of the infection prevention control practices. Are they up to date? Looking at the facility, is it set up for outbreak modality? Do they have the amount of staffing they need, both in the time of non-outbreak, and then what would happen during times of outbreak as we're undertaking there? And of course, the prevention or availability of personal protective equipment, and then timely testing to assess and develop the various interventions accordingly to bring the outbreak under control, or ideally to eliminate it from even getting into those centers at that time. And knowing these different types of congregate settings have a variety of different clientele that are in them, and some are at more risk than others, we want to be cognizant of that as we ask our public health units and our partners in the other ministries to partake in that risk assessment to ensure we get the majority of the right resources to the right centers at the right time to look for the overall protection and reduction of morbidity and if hopefully mortality as well in those settings. So much going on, much testing happening, and we'll give more updates as we progress. And with that, I'm going to open up for questions.
Okay, we'll go to the phone lines.
First question comes from Rob Ferguson from the Toronto Star. Please go ahead.
Hi, Doctor. So we heard the Prime Minister this morning agree to sending the team. Do you have any more details when you were going some boots on the ground, so to speak? How long that will take?
I think you're coming in out there, Rob. I think you're asking about the Prime Minister's announcement related to armed forces helping or assisting in Ontario, and you wonder if we had more details in that besides just they're coming to Ontario. The details are being worked through our a long-term care IMS working group under Dr. Smith, and they're assessing where they might utilize. We understand there's about 5 teams. The composition is not detailed yet. We have some ideas generally, and we haven't yet determined, or they haven't yet determined, which sites they would go to assist, especially both the that group that's there. It deals with some of the hospital ones already, where you've had a couple where some of the hospital centers, both here in Trillium as well as in Lakeridge, have been involved in assisting with the group as working through with a IMS team with Dr. Smith, and then how they might bring in those resources also to assist that when these homes are in outbreak and a lot of their staff are quarantined or isolated, if you may, that really does compromise and it overstresses the staff and has the potential of leaving a lot of the residents without adequate care and coverage, especially during an outbreak modality. And so to utilize that kind of expertise and more than just boots on the ground, but expertise on the ground from their own respective knowledge base and expertise and professionalism in the armed forces to assist in that and coordinating with our IMS group. So more details to follow, and we'll wait for that direction from Dr. Smith and team.
Follow-up?
Yeah, are there any criteria that you're looking at? Given that you were just saying some nursing homes have hospitals helping them. So where are these homes most likely to be? Could they be out in outlying areas where they're not getting a lot of assistance?
I haven't got that kind of detail. The committee has not reviewed and come forward with their recommendations. They're working at that. They were starting with a list of about 13 to 15, trying to narrow it down to 5 that would be best positioned. So, no, I don't have the details on that, Rob.
Next question.
Next question comes from John McGrath at TVO. Please go ahead.
Hi, doctors. You have mentioned, both of you on successive days, that the current state of science suggests that children are not particularly likely to be infected or to transmit COVID-19, and I'm just wondering if, to connect the dots, does that mean that whenever we do start talking about reopening public spaces in the province of Ontario, does that mean that schools will be in the first wave of things to reopen?
So I know Dr. Yaffe talked about the studies yesterday, and we're having ongoing discussions at the federal, provincial, territorial committee meetings in there. And Dr. David McEwen and his team with the Public Health Measures Table are putting that into the further equation to look at in that aspect, because one of the public health measures was to close the schools, and how and when they might be reopened depends on the information, some of the science and evidence, because it is evidence-based, and also driven by the epidemiology and the data as our overall community spread numbers. We would want to have them drop quite considerably and get our so-called transmission rate well below the so-called R0 of 1.0, even down into the lower levels there, because then, as Dr. Yaffe said yesterday, while the science so far shows that children have not been a major vector of transmission, they can be positive at times when the rest of the family is harboring or having been in that state. So we want to make sure that that is not a case occurring before we do that. So in a way, the community side does impact the school side, and so that we would not want to introduce that as a potential vector back into the community. So all in the equation, all to be considered, but nothing of any definite details right now, as we're in consultation regularly with the Ministry of Education, both with the deputy and with the minister in this regard.
Follow up?
Given that as a parent of a small child, trying to keep them 2 meters away from other small children is challenging, and I'm just wondering if you could talk at all about what kind of measures the government will be imposing or recommending to school boards in terms of trying to maintain some limits, even if the full sort of spectrum of social distance isn't possible.
You go ahead.
I'll, and this is based on our knowledge at this point, and of course we're learning as we go. But I think the most important thing, really, is hand washing and having good access to hand washing facilities or alcohol-based hand sanitizer. And so depending on the age of the child, obviously making sure they know how to wash their hands really well and they have time to go, there's access. I think one of the other very important things is not to let the child go to school if they're sick. And I know this is an issue for parents. My kids are grown up already, but certainly when they're little and you need to get to work, it's kind of tempting to give them a Tylenol and send them off. But that is not a good thing to do. They will, first of all, it's not good for them, and they will spread it to other people. And screening, there might be some kind of screening put in place for both staff and children going to school. And looking at how to maintain some kind of physical distancing, given the challenges. But, how close are the desks to each other? What kind of activities can they play? It's not simple, it's not black and white, but those are the kinds of principles we would be looking at, I would say.
Next question.
Next question comes from Sabrina Nanji from Queen's Park Today. Please go ahead.
Hi, doctors. I'm wondering about home care workers and particularly your directives when it comes to PPE use and reuse. We've been hearing concerns about the risk of spread because they've been going from home to home. So what is your advice to them?
Yes, I think that is an important area. And certainly our advice is that they should be wearing a surgical mask at the very least. And using good hand hygiene. And if the client or the patient has any symptoms of COVID, obviously they need to wear facial shield, gown, gloves, and so on, and make sure the person gets tested if they haven't been tested. I have heard there have been issues with access to PPE, and that's something that the worker should be taking up with their agency.
Follow up?
Okay, thank you. And just to follow up quickly on that, has there been any direction, beyond what you've already said about the reuse or resanitizing of PPE for those workers?
I think we're still waiting for advice on the reuse of masks. I think the general advice around surgical or procedure masks is that you have to be very careful with donning and doffing. You can contaminate yourself. But if you are using it, you cannot, once it gets dirty or soiled or wet or in any way, it cannot be reused. And with N95 masks, which generally wouldn't be worn by these people, I don't think we yet have a standard way of sterilizing or decontaminating them that's been approved, to my knowledge.
Okay, next question. I believe this is the last caller.
The last question comes from Phyllis Perkins from CHCH News. Please go ahead.
Hey there, doctor. Just wondering, seeing that obviously we've expanded our testing, we're also seeing higher numbers of confirmed cases. I know we talked about a little bit off the top and we're looking for better ways to break down the numbers, but do we have an idea how much of today's new confirmed cases are long-term care? And if it is, and with the community as well, is that just more people coming forward to the assessment centers, or are people getting sick after 2 weeks of exposure?
So, yeah, I was talking about that at the outset about how the number of the 634 is a composite. The increase is a composite of one, the assessment centers seeing more people and opening a wider definition of cases. At the same time, long-term care and retirement home numbers are in there, and how much the IFAS data, that's the 634, is impacted by the long-term care numbers, which I said is 305 new cases in there, and retirement homes have over 100, just over 100. So you can see that a good proportion of that 634, and again, it's not quite exact because the long-term care one is more administrative data, while the IFAS is a bit delayed because it's the epidemiological data. But it probably gives you a sense that of the 634, a large proportion, well over 60% may be due to the long-term care one. And as we do even more and more testing, we're going to see that number increase in there. And you'll see we're going to have to, as I said at the outset, hoping to get our data people to segment the two away apart from each other so that we, for the public's consumption as well as our modelers, get a better sense of how does the community curve going as compared to that of the outbreaks in the long-term care and the and maybe separate one, who knows, for retirement homes if we have to need that. And I don't know yet whether they're going to use one for congregate settings at this stage. So all part of the looking at the different aspects of this evolution of the COVID-19 in our various communities and parts of Ontario.
Follow-up, and this will be the last question.
And the Premier today said numerous times that the system is the problem with long-term care facilities, and they need to change the system once this is all said and done. Looking ahead, how would you change the system?
Well, not being the the Minister of Long-Term Care or the Deputy, I mean, we're open in public health to give some suggestions, but we're not in that phase of system review right this moment. We're in the midst of dealing with the outbreak and trying to curtail it and deal with that in various things. And this is the first time any sector's dealt with a pandemic, and so it's no small matter. And so all part of that would be in a review process if in that day when we finally can step and look back at it, and that's all part of what the direction is and how well we all were and dealt with the very first big, large global pandemic, because we haven't had any previous experience in this regard. So it tests all systems in that regard, and it certainly has been a challenge for us here, Ontario, Canada, and globally as we deal with a new and novel coronavirus and its impact on our various sectors of our society and our systems.
Okay, thank you, everyone.